I'm Dr. Sabrina Siegel with the Neuroscience Education Institute, and twice a month I sit down with a renowned mental health care expert to discuss breakthroughs and best practices for treating patients with mental illness. In this episode of the NEI podcast, we are discussing drug interactions with Dr. Patrick Finley. Dr. Finley is a professor of clinical pharmacy at the University of California at San Francisco. He's also a board-certified psychiatric pharmacist and has been a licensed medical provider for the last 15 years. Welcome, Dr. Finley.
Thank you.
Dr. Finley, could you share with us some of these statistics on drug interactions?
Well, I have to say that I think the risk of drug interactions is massively underestimated and often misunderstood. I think it's particularly an issue with psychotropic medications as well as with the elderly. The estimates are that elderly patients on average consume between 6 and 8 prescription medications daily. And epidemiological data suggests that if someone's taking 8 prescription drugs daily, that there's a 25% risk of a moderate to severe interaction occurring. Furthermore, among people hospitalized for adverse drug experiences, 1 in 6 of these hospitalizations are actually due to drug interactions.
What are some of the major stages of the pharmacokinetic process of drug metabolism?
Well, the fundamental pharmacokinetic process is absorption, distribution, and then elimination, be it hepatic or renal. And actually, drug interactions could occur at any step in that process. Even at the absorption level, there are some significant interactions with psychotropic medications. For instance, some of the atypical antipsychotics are significantly affected by the presence of food when someone takes an oral medication. With ziprasidone or geodon, the plasma concentrations approximately double if someone takes it with food. Similarly, with lorazepam or Latuda, there's an approximate doubling. Those are probably the most prominent examples of absorption interactions. Distribution interactions are, I think, a lot more complex and not as well described, at least from a research standpoint. We know in general that the integrity of the blood-brain barrier can change based on one's age and whether or not they have, for instance, Alzheimer's dementia. In general, in older people or those with dementia, the blood-brain barrier is much less selective and medication passes more readily into the central nervous system. And so you may see these dramatic responses to medications like benzodiazepines when they're administered to an older person.
Now, I know you just touched on some of these, but could you expand a little bit more on what some of the factors are that can alter absorption, distribution, or elimination of a drug?
Well, definitely the presence of food in the stomach. In general, for certain medications, if someone takes a medication with food, there's much greater absorption. GI transit time actually slows down, and as a result, more drug is absorbed into the central compartment. But I think the number of clinically relevant drug interactions that occur at the absorption step with psychotropic medications in particular is pretty limited. With distribution, I mentioned how the integrity of the blood-brain barrier can change. Another factor that I didn't mention is that there are something called transport proteins which exist at the blood-brain barrier itself, probably the most notorious of which is P-glycoprotein. P-glycoprotein is responsible for taking medication out of the central nervous system and into the peripheral compartment. And some people, from a genetic standpoint, lack the ability to make a lot of P-glycoprotein. So you could actually hypothesize that the medication will stay in their central nervous system for longer and have an exaggerated effect.
That's so interesting. Can you explain what cytochrome P450s are and why they're important when it comes to pharmacokinetics?
Sure. Cytochrome P450 is an enzyme system in the body. Where the name comes from is simply that cytochromes are heme-containing enzymes that are found not only in the liver, but also in the GI tract and the kidneys and the lungs and the brain. Why they're relevant is that the cytochrome P450 system is largely responsible for what are called phase 1 reactions. This is metabolism, for example, demethylation or hydroxylation, which may actually produce an active metabolite. as opposed to phase 2 reactions, which generally are reactions which make drugs more water soluble so they can be eliminated renally. So at least from a drug interaction standpoint, we're usually more obsessed, if you will, with the phase 1 reactions occurring via these cytochromes. There are different members of the cytochrome P450 system worth distinguishing. Certainly the most relevant is the cytochrome P450 3A4 isoenzyme. And I say it's the most relevant just because over 50% of all dispensed medications are actually metabolized via CYP3A4. In psychiatry, I think we're a little more interested in the interactions which occur via cytochrome P452D6 because about 25% of medications are metabolized via this isoenzyme. And what's important about the psychiatric medications is that a number of them actually inhibit the activity of this isoenzyme.
We know that there are a number of antidepressants that are potent inhibitors of CYP2D6. What are some clinically relevant drug interactions which can occur via that isoenzyme?
I think the two biggest medication classes we're concerned with when it comes to inhibiting CYP2D6 are certain beta blockers and certain narcotics. To explain, beta blockers like metoprolol and propranolol are widely prescribed, and a functional CYP2D6 isoenzyme is required for them to be eliminated. If you give someone an antidepressant, which is a potent CYP2D6 inhibitor, and I think the classic examples are fluoxetine, duloxetine, paroxetine, and bupropion. Well, if you give someone one of those 4 antidepressants and they were previously stabilized on a beta blocker, their plasma concentration will go up anywhere from 200 to 400%. Which is like quadrupling their daily dose of that beta blocker. And actually recent evidence has emerged that this can result in an increased risk for falls, bradycardia, and hospitalization. So with the narcotics or opioids, the situation is a bit different. Certain opioids are actually what we call prodrugs, and that means they have to be metabolized in order to become active. The most notorious example is codeine, which really doesn't have any analgesic effects until it's metabolized to morphine. And this occurs via the CYP2D6 isoenzyme. So if someone is either a poor metabolizer for CYP2D6 or they're receiving a CYP2D6 inhibitor, basically they can't form an adequate amount of morphine to provide any analgesia. In fact, there are actually studies showing that patients receiving codeine who have their pain successfully managed, if you give them an inhibitor of CYP2D6, the pain returns. Other examples with opioids, which I think are really relevant, are with tramadol in particular, which is also a prodrug, and possibly with oxycodone and hydrocodone.
Wow. I think this is such valuable information for people to know. Could you share with us the research findings that compared hip fractures in patients over 64 who were taking only benzodiazepines versus those taking benzodiazepines combined with CYP3A4 inhibitors?
Certainly. Yeah, so CYP3A4, the scenario's a bit different. There aren't as many potent CYP3A4 inhibitors among psychotropic medications, but I think there are still some relevant interactions here. For instance, the benzodiazepines, many of them actually require an active CYP3A4 isoenzyme system in order to be metabolized. Personally, I was never that alarmed about the potential for drug interactions occurring via CYP3A4 with the benzodiazepines, just because I always rationalized that, well, we're titrating to effect, we're using them on a PRN basis, so the clinical ramifications wouldn't be as significant. But then a really interesting epidemiological study came out a few years ago where they were looking at patients who were on the benzodiazepines alprazolam, lorazepam, or the Z drug zolpidem, all of which are 3A4 substrates. And they were comparing the incidence of hip fractures among patients who were just receiving one of those substrates versus those who were on the substrate plus a 3A4 inhibitor. And there was an approximate doubling of the risk of hip fractures if they were on a 3A4 inhibitor, which is indirect evidence that by inhibiting the metabolism of the benzodiazepine, you're increasing the plasma concentration and then therefore increasing the risk for falls.
How does grapefruit affect drug interactions?
Well, grapefruit also inhibits the cytochrome P450 3A4 isoenzyme. Unfortunately, most of the evidence of the interactions occurring with grapefruit have been done in prospective studies where they used what are, I think, really large doses of grapefruit juice, on the order of 12 to 16 ounces of grapefruit juice. But it does look like there can be a significant interaction there. There have been studies done with midazolam that I'm aware of, where if they received grapefruit juice within 2 hours of midazolam administration, that there was about a 50% increase in plasma concentrations with midazolam. What's kind of interesting about these interactions with grapefruit juice is that it looks like if the medication has what we call a high first pass effect through the 3A4 isoenzyme, it's a much more significant interaction. So the drugs we're particularly concerned with there, which have this really high first pass effect, are medications like buspirone, ketamine, lorazepam, and quetiapine. All four of these have a really high first pass effect, which means there's low bioavailability. And if you're inhibiting this CYP3A4 isoenzyme, well, what happens is you're absorbing it much better, and it's not going through the liver immediately after absorption. And as a result of that, there's higher plasma concentrations.
Now, I know that you touched on this earlier, but could you share with us a little bit more about the importance of P-glycoproteins in pharmacokinetics?
Sure. I have to admit, I think a lot of it's theoretical at this point, but on another level, it's really fascinating. Again, P-glycoprotein is a transport protein which exists basically at the level of the blood-brain barrier, and it's responsible for taking drug out of the central nervous system. There is some genetic predisposition in terms of how well one makes P-glycoprotein. Some people basically have a phenotypic variation where they don't make a whole lot of P-glycoprotein, so you could theorize that they're going to have a difficult time getting drug out of their central nervous system, and these may very well be the people who are more sensitive to the effect of psychotropic medications. What's also interesting about P-glycoprotein is that certain medications are P-glycoprotein inhibitors. And if you give someone a P-glycoprotein inhibitor, you're going to decrease the activity of that transport protein. And again, what you're going to see is an accumulation of drug in the central nervous system. The medications, I guess the more prominent medications, which are PGP inhibitors, are things like flufenazine, sertraline, paroxetine, fluoxetine, and others.
Wow.
Similarly, there's a number of psychotropic medications which are PGP substrates, like benzodiazepines, certain tricyclics, and citalopram.
Wow. That's so interesting. What is serotonin syndrome? Could you share with us some of the symptoms and what some of the risk factors are that are associated with it?
Certainly. Serotonin syndrome is a rare and idiosyncratic but potentially fatal syndrome. Classically, where we've seen cases of serotonin syndrome described are when people take two medications or more, which enhance serotonergic activity. The theory is that there's basically excessive serotonergic activity, and this leads to symptoms like mental status changes and chills and sweating. Myoclonus is frequently one of the first, I think, serious symptoms that something's going on. And the big risk, of course, is malignant hyperthermia, which can result in fatalities. What's kind of tricky about serotonin syndrome is we don't know which exactly are the most dangerous combinations because we really can't do prospective studies examining, what are the worst combinations. It's just not ethically feasible. Mm-hmm. And so the evidence we have of these interactions are entirely retrospective. So basically what we have to ask ourselves are three things. First of all, how many case reports of serotonin syndrome are in the literature or reported to the FDA? Secondly, how impressive are these case reports? I mean, is it true serotonin syndrome? And then thirdly, we need to ask ourselves, well, how often is this unique combination of drugs combined? I think a great example of how difficult it is to truly anticipate the risk of serotonin syndrome is with the migraine medications known as triptans. Several years ago, the FDA came out with a warning about not combining triptans with the antidepressant class known as SSRIs or SNRIs. The reason being that they thought excessive serotonergic activity between those two could result in case reports of serotonin syndrome. But then actually the American Headache Society did a subsequent analysis looking at just how commonly these two classes of drugs are combined and how rare it is that any verifiable case reports have actually been captured in the literature. And ultimately, the American Headache Society came to the conclusion that current evidence does not support limiting the use of triptans with SSRIs. Again, it kind of gets at one major factor you have to take into account here is how commonly those drugs are given together and what is the true evidence that a significant risk is incurred.
Right, right.
Among the medications that have been commonly associated with serotonin syndrome, it looks like the greatest risk can be found with the MAO inhibitors. MAO inhibitors are the older, maybe the oldest class of antidepressants actually. And when they were combined with tricyclic antidepressants or SSRIs, there were a number of case reports of serotonin syndrome. But what's kind of interesting about that is that many patients actually did tolerate the combination of MAOIs with tricyclics, which kind of gets at this issue of how serotonin syndrome can be largely idiosyncratic. In terms of which classes I think are the most dangerous, I would definitely say that the MAOIs are, and I'm just not willing to tolerate a risk of combining an MAOI with an SSRI or an SNRI. I think in my mind that's an absolute contraindication. Other drugs which I think I would consider a contraindication are atomoxetine, amphetamines, sibutramine, meperidine. Some of the opioids actually have potent serotonergic activity. So again, any of those medications combined, I think, carry substantial risk. One gray area is with tramadol. I'm frequently asked, can I prescribe SSRIs with tramadol? And in my mind, the answer is no. If there's any other options, I would pursue those other options just because the number of impressive case reports of serotonin syndrome with tramadol and SSRIs, at least to me, is unacceptably high. It all depends on how much risk you want to take on.
Wow. Thank you for sharing all of that. That was such great information. What is the relationship between CYP2C19, SSRIs, and QT prolongation?
Well, in 2011, the FDA came out with a warning that citalopram, and many people also assume the same warning applies to S-citalopram, was associated with an unacceptable risk of QT prolongation, which could lead to malignant arrhythmias, namely torsades de pointes. Specifically, they found that there was a higher risk in older people receiving more than 20 milligrams a day of citalopram, or in younger people receiving more than 40 milligrams a day. Now, where the gray area here is just how high was that risk of QT prolongation and how significant was this QT prolongation. And there have been some retrospective studies done since this warning came out, which suggests that the risk is not quite as great as we originally believed back in 2011. But still, I think if someone has underlying QT prolongation or they're on another medication which causes QT prolongation, we should really be concerned about prescribing citalopram or S-citalopram at the same time.
Wow. Thank you for sharing that with us. My final question for you is, how important do you think it is, based on all of these research findings and all of this information, for patients to be tested for pharmacodynamic and pharmacokinetic genetic variations?
I think the value of genetic testing or pharmacogenetic testing at this time has still not been well documented. There are certain, I think, exceptions where genetic testing may be indicated. For example, with medication atomoxetine, which is used for the treatment of ADHD, we've seen that depending on whether one's a poor metabolizer versus an extensive metabolizer, there can be a 10 to 20-fold variation in plasma concentrations. So most of the recommendations today are that if someone's going to be receiving atomoxetine, it probably is worthwhile to do a genetic test. There is an international organization known as PharmGKB, and they come out with recommendations in terms of whether or not they think it's of clinical value to do genetic testing. They certainly endorsed that with atomoxetine, and actually, interestingly, they also endorsed it with citalopram and S-citalopram. I also think there's other instances where genetic testing can be valuable when it comes to prescribing psychotropic medications. Probably the one that's most intriguing to me these days has to do with the MTHFR enzyme. It has to do with basically folate metabolism. If people take folic acid orally, it has to be metabolized to cross the blood-brain barrier. Ultimately, it's the methylfolate, metabolite L-methylfolate, that's responsible for serving as a cofactor for neurotransmitter synthesis. So someone who lacks the MTHFR enzyme, at least in theory, will not be able to make a whole lot of the active species of L-methylfolate, which crosses that blood-brain barrier, and as a result, they may be relatively deficient in neurotransmitters. There has been some research suggesting that supplementation with L-methylfolate can actually convert antidepressant non-responders to responders. I have seen examples personally, anecdotally, where it was worthwhile to actually check the activity of the specific isoenzyme. But beyond these examples I've listed, I haven't seen a whole lot of widespread use of these genetic tests that can be justified, at least from an evidence-based medicine standpoint.
Okay, well, thank you so much, Dr. Finley. Thank you for being on the show, and thank you for sharing such great information with us.
Oh, my pleasure. Thanks for having me.
This podcast was brought to you by NEI. Not able to attend one of our live conferences? NEI releases recordings of the sessions presented at our 2 annual conferences, NEI Congress and NEI Synapse. Presentations are freely available online, and there are more than 90 CME credits available for NEI members. For additional information, see the link in the podcast description.